Okay, all right, it's 2 o'clock. Let's get started. Welcome everybody to this webinar on the World Falls Guidelines for Prevention and Management of Falls in Older Adults. Now I'm hoping that you can all see me and that you can all see the presentation. Those of us that will be presenting, I'm Sue Kitchen. I'm a Falls CNC at Sir Charles Gardner Osborne Park Care Group. We have Diane Robertson, who is OPI Coordinator in WACS, Great Southern, and Lisa Campbell, who is a Senior Physiotherapist at Fremantle Hospital. So about the presentation, the guidelines themselves are extremely detailed, and all we want to do is provide you with an overview and just a little bit more information that will help you to understand them. The style of the presentation is very much that we have given you all of the information. The slides are quite text heavy, but that is so that we can provide that information for you so that we can give you the PowerPoint afterwards and you have it all there. You don't need to go and do any work. You can just cut and paste, or you can present the whole thing to your colleagues. We are recording, so obviously if you choose not to be recorded, you need to leave this webinar now. The ad hoc groups, so we have working groups within these guidelines, and then at the end of that there's another 10 ad hoc groups which we'll explain. I don't think we're going to get to those, but we have listed them so that they are available for you when we send out the presentation. So the guidelines were published in September this year, and the objective was to create a set of evidence-based and expert consensus falls prevention recommendations. They're applicable to older adults, and they can be used by all types of healthcare and all healthcare professionals. They use the Delphi process to identify the recommendations. Now, the Delphi process is a process that is used to arrive at a group opinion or decision by surveying a panel of experts. So the experts respond to several rounds of questionnaires, the responses are aggregated, and they continue to adjust their what they believe, what their opinion is, based on what they're reading, until they come to a consensus. There are 12 topic-specific working groups, one of them that we won't be covering, and 10 ad hoc groups, as I said. And there is a working group that has dealt with the perspectives of older adults, which is brilliant. It's actually extremely interesting reading. Sorry, could you all just check that you have your mics muted? There's somebody who hasn't. Thank you. So the overall recommendations, when you download the recommendations off the net, you can have the short version, which was in Age and Aging, or you can have the long version, which is off the website. The long version, which we're presenting today, is around 130 pages. The short version is much more succinct, but it advises that all older adults should be advised on falls prevention and physical activity, and that we need to use those opportunities that we have touch points with people to identify if they are at risk of falling. And this is recommended for all adults, but particularly community dwelling older adults, which we'll go into. High-risk fallers should be offered a comprehensive multifactorial falls risk assessment, and then you co-design and you implement personalized multi-domain interventions, all a bit of a mouthful. And there are recommendations for specific settings and for specific populations. So these are the this is what it looks like in the long version of the guidelines. You will have the front page, and they list all of the working groups along with the recommendations and what grade or how good the evidence is. So succinct. Some of the key messages that we need to be listening to are that the world's population is aging, but many falls can be prevented. But equally, those falls and those related injuries really are a critical global challenge. So it's not just happening in your area or your hospital or your community or this state, it's happening everywhere. We need to engage with older adults about understanding their beliefs and their attitudes and their priorities, because that is going to be crucial to the falls management. And we also need to note the very important association of falls with other geriatric syndromes and conditions. So the framework that the guidelines provide is a falls risk stratification, which is a standard approach to assess an individual's estimated level of a risk for falling. The assessment is obviously the process of identifying and measuring those falls risk factors across multiple domains using all the recommended tools to identify the areas that we need to put interventions into place. The next part of the framework is the management and the interventions. So a description of various approaches to falls prevention. They might be single interventions, or they might be interventions that come in a combination, but that is more usual. They also have an assessment and treatment algorithm, and that links 3 stages of the risk stratification, the assessment and the management, and it does make sure that there is a person-centered approach to designing those individualized interventions or that individualized care plan for falls prevention. So this algorithm is for risk stratification, and it's about the touch points really for community dwellers and those that are presenting to emergency department. So if you have somebody, a community dweller, older adult who is coming into your GP or into ED, then they suggest that you follow this algorithm. So let's just say we have somebody that is coming to ED. That would be, I'm hoping you can see my mouse. So they're coming through to ED. Have they had a fall in the past 12 months? If it's no, then they're considered low risk, and this is the advice that you need to deliver to the patient. So education and advise physical activity. If it's a yes, then these are what we need to be looking at. We need to assess the severity of the fall, whether there was an injury, how often are they having falls. And then the algorithm just follows through. If it's no to any of those, or all of those rather, then have they got a gait or balance impairment? No. Low risk, provide advice. Yes. Then we need to start talking about tailored exercise interventions. And so it's quite an easy algorithm to follow for the community and on admission to ED, not in hospital or in care homes. So categorization into these groups, low risk, medium, or high risk. This is for GPs and those presenting to ED. This is not for hospitals or for care homes. And so with low risk, offer education. Medium, we need to start to have a targeted exercise or physio referral. And if it's high risk, we need to do the multifactorial falls risk assessment and individualized interventions. So as we go through the recommendations that have been given by the World Guidelines, they have graded the strength of their evidence. So A1 means it's pretty much as high as you can go. It's the best possible evidence. And then we work downwards from there to an E, which is expert. So there's no evidence available, but on the consensus of the experts within the World Falls Guidelines, this is what they recommend. It needs to be person-centered. So it's a framework within a framework. It needs to be predictive, so we need to utilize the available information to identify a person's risk of falling. We need to be preventative, so we need to focus on what we can do to prevent falls or reduce the risk. It needs to be personalized, and the personalization comes through all the time, right the way throughout these guidelines. It needs to be personalized to the person, individualized. And participatory. So we need to make sure that the older adult and their chosen caregivers are involved in the development of a falls management plan. There's quite a few different changes in terminology, and so you need to be aware of that. I've put a few up here that we will use today. The fall is the WHO fall, but they have actually also added in a syncope, specifically a syncope in that. So not only do we have an unexpected event, but a syncope as well. Multi-domain interventions. So these are a combination of 2 or more interventions that go across more domains. So essentially multifactorial. We have risk stratification, so that's how we're approaching the standard approach to assess the risk of falling or the predictability of falling. The multifactorial risk assessment, the MFRA, is a set of assessments that you perform to identify what the risks are and what interventions need to go into place. Caregiver. They're very specific about this in the guidelines, is the caregiver, and there's formal and informal. So informal is, for example, the family member. Formal is the healthcare professional that is delivering care. And then FRIDS, we've often heard that terminology, so falls risk increasing drugs. Okay, I'm going to hand over to Lisa now, and fire away, Lisa. Let's get cracking on working group 1.
Thanks, Sue. So working group 1 is looking at gait and balance assessment tools to assess for falls risk. Next slide. So the objective of this working group was to make evidence-based recommendations on assessments of gait and balance to predict falls. The first recommendation relates to the risk stratification and is relevant for all clinical settings. For risk stratification, the guidelines recommend using gait speed for predicting falls risk with a cutoff value of less than 0.8 meters per second on the basis of its predictive value and simplicity, and there's grade 1A evidence for this recommendation. The timed up and go is recommended as an alternative test with grade 1B evidence. The evidence for the use of the timed up and go for falls risk stratification is mixed, but there is some evidence that the TUG is predictive of falls in lower functioning adults. The guidelines were unable to recommend other tests such as the Berg Balance Scale or Functional Reach as standalone tests for the prediction of falls in community dwelling older adults, but the guidelines do recognise that these tests have value in the assessment of balance and mobility to target interventions and recommend their use as part of your assessment, but not as standalone measures for risk stratification for falls prediction. With regards to some of the clinical subgroups, again, gait speed is the recommended measure within all the clinical settings for predicting falls. However, as I've mentioned, there's some evidence for the TUG for having a role in predicting falls for older adults with lower function. And for other clinical populations, the Berg Balance Scale may have a role in predicting falls in a stroke clinic population, while another study they reported was that the Functional Reach may be useful predicting falls in older adults with cognitive impairment. In terms of the research priorities, so further research is needed to evaluate how different tools combining balance and physical function assessments, like the short physical battery performance tool, can be used to predict falls. More research is also warranted to determine the most appropriate dual tasking protocol for falls prediction. A third research priority is to determine the best combination of assessments for different clinical groups and different clinical settings. And then the guidelines also mention that there is increasing research in the development of falls prediction models, which combine data from different domains to calculate falls risk. Next slide, Sue. So the second recommendation from this group relates to assessment, and the recommendation is that balance and gait should be part of the assessment with grade 1B evidence. So as mentioned, the gait speed and the tug are the outcome measures for predicting falls risk. But when it comes to actually assessing mobility and balance, the guidelines recommend a number of well-known outcome measures as listed on the slide to help identify the balance and gait impairments and target interventions appropriately. The choice of assessment should consider the clinical characteristics of the older adult, the setting and the resources that are available. They recommend that balance can be screened using something simple like the single leg stance or tandem stance, and then if indicated that a full structured assessment should then be completed. For gait, recommended that it's assessed both qualitatively and quantitatively, and a structured assessment of gait by a trained clinician is recommended to assist with directing investigations for underlying conditions that may increase falls by impairing gait. On this slide, I've also included some other aspects of the gait and mobility assessment that are mentioned in the assessment part of the guidelines, and that's for your reference, but just to say that they weren't all reviewed by this particular working group. With regard to monitoring and evaluation, the guidelines recommend that we use established minimal level of changes to monitor the effect of interventions and also to consider clinical meaningful changes. And finally, from this working group, just to mention that within the guidelines, there are a couple of links to websites that have a range of outcome measure resources. Thanks, Sue.
Thanks, Lisa. Okay. Working group 2. So this was looking at polypharmacy and FRIDS, falls risk increasing drugs and falls. The objective of this first recommendation, and this is around assessment, was to summarise the available literature regarding FRIDS. It's relevant for all clinical settings. So when I say that, I mean community, hospital and care homes. And the recommendations are to assess for a falls history and a risk of falling before prescribing FRIDS, and the grade is 1B. It provides a lot of practical tips within this particular recommendation. So many initiatives and tools that are available to use. And one that I keep hearing time and time again, just very recently, is the Stop Fall. And the guidelines provide links to all of these so that it's very easy to look up and to see which you want to use. Decision making should be shared with the patient and with their caregivers, and at a minimum, an annual medication review should occur annually, but it does say it's preferable to be 6 monthly. For the if you're looking at different subgroups, it's just saying that basically FRIDS is a severe issue. It's relevant to everybody. What they would prefer is that there's no prescription of FRIDS if possible. Use suitable alternatives, look for suitable alternatives, or look at when it was prescribed or how it was prescribed, etc. Recommendation 2 is around assessment. So we're still in the same working group, still looking at polypharmacy and FRIDS, and it's still relevant for all clinical settings, but it is particularly relevant for the hospitals. They recommend to use a validated and structured screening and assessment tool to identify the FRIDS. And their practical tip here is to use the Stop Fall screening tool, and I have provided the link there. Using these tools improve reviews and appropriate deprescribing. I actually went through this screening tool. I had a patient, and just out of interest's sake, I took the medications that they were on through this screening tool, and actually was able to get a couple of these deprescribed after discussion with the medical staff and the pharmacist. So there is a role for a screening tool like this. Their research priorities is what they've suggested is that we look at further studies to demonstrate the effectiveness of Stop Fall in all of the other clinical settings.
Is it pretty bad in there? It wasn't too bad. I went late Saturday to do the shopping.
Yeah,
It wasn't.
tomorrow was funny, but I decided I didn't need to shop on.
Recommendation 3 is around intervention. So the medication reviews and the deprescribing should be included in a multi-domain falls prevention intervention. So basically, it needs to be one of those interventions that we put into place as part of a multifactorial suite of interventions. Again, the deprescribing of FRIDS and the medication review, the evidence is grade 1B. They suggest that it should be performed within a CGA, which is a comprehensive geriatric assessment, which I don't know about other settings, but certainly in hospital, we will find that occurring quite a lot. The review should always be holistic and very personalized. And again, there should be that shared decision making with the patient and with their caregiver. Recommendation 4 is another intervention, and it emphasizes the importance of a medication review in long-term care. And this recommendation is specifically for long-term care, so for those care homes. And it's about education of the older adult and the family and healthcare professionals, again, coming back with that shared decision making. Frail subgroup deprescribing is probably going to be a standalone intervention, but you do need to go back to the guidelines for this particular recommendation to find out more information. Implementing is about engaging with everybody and education and making sure that there are adequate protocols for deprescribing available. So my question to you guys out there is, in the care homes, do you have a protocol for deprescribing? Do we have one in the hospital? Oh, I don't know actually, but perhaps this is something that we need to be looking at. We need further studies to find out how to optimize that deprescribing in the long-term settings. They also have suggested using a structured approach as determined by the NICE guidelines. And again, there is a link there for you to be able to access that. Working group 3 is the cardiovascular risk factors for falls. This is quite an extensive working group. And again, I really advise you to go and have a look at the full guidelines, not the abbreviated version. The first 2 recommendations are around assessment. And they have listed the most common cardiovascular causes of falls in rank order. And up there at the top is orthostatic hypertension. Then we have vasovagal syndrome, carotid sinus hypersensitivity, bradycardia, and then other arrhythmias. These recommendations are relevant for all settings, all clinical settings, and should be they should be a multifactorial risk assessment, which includes the cardiovascular history, auscultation, lying and standing blood pressures, and a 12-lead ECG. That evidence is grade 1B. And no other abnormalities If there isn't any abnormalities, then there doesn't need to be another assessment unless anything changes, and that's grade 1C. Practical tips is if the person falls, then it's imperative to get the witness account as soon as possible to determine if a transient loss of consciousness occurred, because that's what we need to know, because there's a problem, there's a cardiovascular issue, and we need to be looking at this. This is the contributing factor to the fall. Recommendation 3, again looking at assessment within the cardiovascular working group, relevant for all settings. We need the cardiovascular assessment for an unexplained fall, for a syncope, needs to be what has just been completed for a multifactorial falls assessment. So that's grade 1A. And then recommendation 4 and 5, which is interventions. It's relevant for all clinical settings, and this concerns orthostatic hypertension. So this is a component of the multi-domain intervention, and this is what needs to be done. It's one of the highest contributing factors from a cardiovascular perspective for falls, and the evidence here is grade 1A, so it's top evidence. It does say that we need to look at how medications are prescribed at what times a day. So instead of giving all of the medications that might be dropping blood pressures first thing in the morning, perhaps try and stagger them throughout the day rather than having them all in one single dose. With the orthostatic hypertension, need to be looking at the pharmacological and the non-pharmacological interventions that need to go into place. Some areas do have orthostatic hypertension guidelines that help to guide staff on how to deal with orthostatic hypertension. If there isn't, given these recommendations, perhaps this is something that we need to be considering. Lisa, back to you.
Thank you. So the next group, we're looking at exercise and physical activity interventions for the prevention of falls. So the objective, just next slide, Sue, thank you. The objective was to review the literature to assess if exercise compared to usual care can prevent falls in older people. The group looked at a variety of clinical settings and a number of common clinical conditions. So the first recommendation relates to community dwelling older adults. The guidelines recommend exercise programs for falls prevention that include balanced, challenging and functional exercises that are individualized and progressed in intensity. The program should be offered at least 3 times per week for at least 12 weeks and continued longer for greater effect. This recommendation is grade 1A evidence. The second recommendation with grade 1B evidence is the inclusion where possible of Tai Chi and or individualized progressive strength training. These 2 recommendations apply to all community dwelling older adults regardless of their age and regardless of their assessed risk of falling. The exercise programs can be group-based or individualized home programs. It was noted that the vast majority of interventions that were found to be effective used trained providers, and therefore the guidelines do recommend that exercise programs should be delivered by trained professionals where possible. Increasing general physical activity levels outside of the delivered exercise sessions should be encouraged, but older adults should also be made aware that general physical activity alone, for example walking for errands, is unlikely to prevent falls. The evidence shows that benefits of exercise are lost upon cessation, so it is important to provide opportunities for older adults to continue their exercise activity at the end of any formalized exercise programs. Recommendation 3 is that individual supervised exercises for older adults in long-term care settings should be offered to those who are willing and able to participate. It's noted that exercise as a single approach to falls prevention in care home residents is unlikely to reduce falls, but it will also have other benefits for the residents. For Parkinson's patients, which come under recommendation number 4, the strength of evidence for exercise preventing falls in mild to moderate Parkinson's with good cognition is high, so grade 1A. And for this clinical population, fully supervised programs may have a greater effect on reducing falls compared to less supervised programs. And then for adults with advanced Parkinson's, it is recommended that exercise be conducted in supervised settings, as minimally supervised exercise may have an increase in the rate of falls. Older adults after a stroke should be offered participation in programs aimed at improving balance, strength and walking to prevent falls. And patients post-hip fracture, it's recommended that they also are offered the exercise programs and that these be commenced in hospital and then continued into the community. And the final clinical group that clinical condition that this group looked at were community dwelling older adults with cognitive impairment, where there's grade 1B evidence to support exercise programs to prevent falls. Next slide, Sue. In terms of practical tips, so the guidelines suggest offering lots of choice in terms of exercise type, the setting and the amount of supervision that is provided, and this is in order to try and improve uptake and adherence. And liaison between health and fitness professionals is also encouraged to allow seamless pathways for exercise across both health and community settings. As you can see on the slide, there's lots of areas that have been identified as needing further research, but just to mention a couple. So for community dwelling older adults, a lot of the participants in studies to date have been white females. So there is a need to look at the evidence of exercise in different groups, such as males and culturally diverse communities. Further studies are also needed on strength training as a single exercise intervention, and also more research on the effectiveness of other popular activities such as yoga, dance, Pilates, hydrotherapy from a falls prevention point of view. For the other clinical groups, more research is needed on the impact of exercise at the different stages of impairment and also within the different disease subtypes. And finally, some general research priorities are looking at the long-term effects of exercise and also the effect of commencing balance or strength training in midlife on falls in older age. Thanks, Sue.
Thanks, Lisa. Okay, moving on to working group 5. So this is falls in hospitals and care homes. So this is not community. So recommendation 1 in hospital assessment. We really could just do a whole presentation just on individual working groups, and this is definitely one of them. It's a huge group of recommendations with a lot of information and resources and practical tips available. So the objective of this recommendation was to review the literature to assess the multifactorial falls risk assessment and look at scored screening tools. It's relevant for hospitals. So it recommends that we perform a multifactorial FRA, all hospitalized older adults, but it does give other groups which we need to include in this, and this is people with movement disorders and others. It highly recommends that we do not use a scored falls risk screening tool. So they did actually review that, and in the guidelines you'll find a very comprehensive review about the screening, the risk screening tools. Sorry. So they want a multifactorial assessment. Falls assessment should include these following. So falls history, assessment of gait and balance and mobility, assessment of osteoporosis, assessment of fall fracture risk, perceived functional ability and fear of falling, visual impairment, sensory loss, cognition, neurological examination, urinary incontinence, and the cardiovascular examination and medical review. They also recommend that all of the assessments are discussed with the older adult, with their family and their caregivers, and with the health professionals. The risk assessments should be completed as soon as is practical following admission. And the risk assessment should be reviewed if there's a change in adult's condition or a fall. So given what is in place at the moment in the majority of hospitals in WA, we're doing that already, but the guidelines back up the evidence. Individual care plan is required, and that assessment informs the implementation of strategies to reduce the risk of falling. They do need to be, these risk assessments do need to be monitored and evaluated. Recommendation 2 states that a post-fall assessment is required, and it does actually recommend the WA post-fall assessment to be done, particularly in the care homes. So that's interesting from our perspective. Looking at the management and the intervention, we need to review the literature and if education alone reduces falls and what modes are feasible. This is relevant for hospital settings, and there's been a lot of work done over the years in terms of educating patients and staff in falls. So the education needs to be tailored to the individual and to the hospitalised older adult, and that's grade 1A. It should be part of those multi-domain interventions, and the modes of delivery should vary. There should be multiple different types of delivery available. Might not be relevant for those with cognitive impairment, but will be appropriate for their caregivers, informal and formal. So we need to be making sure that we don't just deliver this education to the patients, but we include others. There is something called Teachback, and they have suggested that this is one of the implementation strategies of education that is given. A bit more about Teachback when we get towards the end, but there is also some links within the presentation. So another recommendation relevant for hospital again, looking at multi-domain or single falls prevention strategies based on the risk factors, but also based on behaviours and situation. That's grade 1C, and that is for acute care only. And hospitals should have protocols and policies and guidelines for the prevention of falls, which I would think there's probably not one hospital in Australia or the world that doesn't have a guideline for that. Start to talk about falls from admission, and also look at those environmental strategies as well. Again, if you have an older adult with CI, this information needs to be delivered in consultation with their family and their caregiver. You might need to adjust to a local budget and resources. So if you don't have you just use the budget and the resources that you have. The guidelines are very clear on that, and they understand that many people just do not have a budget and their resources are minimum to do what you can. For care home assessment, no fall screen. So all residents are considered high risk. That's grade 1A, and that's actually the same in hospitals as well. Staff should just invest the small amount of time that they have into a multifactorial falls risk assessment, multi-domain risk assessment and the interventions, and focus on developing smart technologies for the care home. Recommendation 2, again, we're looking at the interventions, making sure that we do the MFRA at admission and implement whatever is required, what comes up from the assessment. Use the WA post-fall guidelines for patients that have had a fall and the tools that are within that. Again, for care home assessment, and this is looking at including post-fall assessment. What they want is to avoid the unnecessary transfer to acute care. That's what they're looking for. And that's expert opinion, so there isn't actually any evidence around that. Further recommendations, and this is looking at restraint as a falls prevention strategy. It is not recommended. That's all evidence grade 1B. It should be a multifaceted approach to falls reduction, and they recommend that there is a multi-domain decision support tool, and it provides resources within the guidelines, and there's a link there to enable that to occur. It also provides a resource which gives you alternative approaches to restraints. Recommendation 3 is around nutritional optimization, and that also needs to be part of the multi-domain intervention for falls. This is relevant for care homes, and they're looking at nutritional optimization and foods rich in calcium and proteins and vitamin D, grade 1B. For care homes that are measuring vitamin D levels, patients should be between 50 and 75 for their level, but it doesn't recommend that these are not necessarily required as long as there is nutritional optimization. It shouldn't actually be required with the patients. It's very complex to implement, but they have found through the evidence that it's very cost effective. Looking at physical activity, so any promotion of exercise is essential. I'm going to skip the 5-minute break. Hope you don't mind. Hope you like the pictures. And we'll move forward. Working group 6. Diane.
Thanks, Sue. So in terms of cognition and falls, dementia and mild cognitive impairment doubles the risk of falls and fall-related injuries, including hip fractures, fractures of the arm and head injuries. So the working group recommends routine assessment of cognition be included as part of a multifactorial falls risk assessment in older adults, and that's grade 1B evidence. And this recommendation is relevant for all clinical settings. Low cognitive performance in older adults, particularly of executive function, even in the absence of known cognitive impairment or formal diagnosis of dementia, is strongly associated with an increased risk of falls. Therefore, cognitive screening tests that include executive function, such as the MOCA or the Trail Making Test Part B, should be used. And the MOCA is available in multiple languages and has recently been recommended as a global cognition test for assessing an interaction between mobility, cognition, and falls. There's no high-level evidence on how frequently cognition should be assessed and monitored in older adults, but expert opinion is that cognition should be an integral part of any comprehensive falls risk assessment. And so, for instance, if a comprehensive falls risk assessment is performed every year, then cognition should also be tested at that time. In terms of research priorities, the group identified that future fall prevention studies need to be more inclusive of cognitively impaired participants, particularly early dementia stages, since this is a population at higher risk of falling with relatively preserved mobility and independence in the community. Next slide, thanks, Sue. So recommendation 2 is around interventions. And the involvement of caregivers. So the working group recommends including both older adults and caregivers' perspectives when creating the individual falls prevention care plans for adults with cognitive impairment, since this strategy has been shown to have better adherence to interventions and outcomes, and that's grade 1C evidence, and this is also relevant for all care settings. Engaging caregivers can raise awareness about falls risk and prevention. For example, how to identify and appropriately modify any environmental risk factors. Engaging caregivers can also help modify lifestyle, so thinking about nutrition and exercises to reduce falls risk, and also support accurate recording of falls incidents. So clearly, given their increased risk compared to those with no cognitive impairment, older adults with cognitive impairment merit much greater focus on falls risk assessment and intervention research. And that's all for that, Sue. And this is me as well. So, looking at specific groups, as Lisa touched on earlier, so speaking about Parkinson's disease and related disorders. So falls are very frequent in older adults with Parkinson's disease and related disorders, and these groups may have specific risk factors and other attributes associated with their condition in addition to the general risk factors found in the older population. So identifying these condition-associated risk factors may assist in choosing the most appropriate individually tailored interventions. So recommendation 1 is around assessment, and the group conditionally recommends falls risk assessment of older adults with Parkinson's and should include history of falls in the previous year, freezing of gait in the last month, and slow gait speed, and that's grade 2B evidence. So in Parkinson's, freezing is the most specific risk factor for falling. One study showed very directly that 61% of falls in Parkinson's were freezing related and can be targeted with specific interventions. For those of you wondering, slow gait as a predictor of falling in Parkinson's is defined as a self-selected gait speed of less than 1.1 metres per second. One of the reasons that people with Parkinson's fall so frequently is the loss of automatic motor control and other modifiable non-motor risk factors such as orthostatic hypotension, fear of falling, and cognitive decline. Reduced executive function and poorer dual tasking may also increase falls risk in Parkinson's. Next slide, please, Sue. So this is around management and interventions. The working group conditionally recommends that older adults with Parkinson's should be offered multi-domain interventions based on Parkinson's specific assessment and other identified falls risk factors, and that's grade 2B evidence. People with Parkinson's generally have multiple factors contributing to falls risk and falls, and therefore multifactorial interventions have the potential to target more than one of these underlying factors at the same time. Studies that incorporated dual tasking exercise, so that's cognitively and physically challenging tasks for at least 8 weeks, showed better improvements in fall rate, near falls rate, and falls risk compared to control groups who received just regular treatment. There was some discussion around context-specific training as well, so training on different surfaces and practicing fall-prone functional tasks, so pulling or pushing doors, exiting or entering, escalators, fast walking, all had a positive effect on gait and balance. One study also looked at virtual reality and treadmill training, and the conclusion there was that rates of falls were 42% lower in treadmill training plus virtual reality, so that dual tasking, compared to just treadmill training alone. So research priorities should focus on the optimal combination, frequency and intensity of interventions for this specific population and longer post-intervention follow-up effects, as the reviewed studies only had a maximum follow-up period of 6 months. Next slide, please, Sue. And the last 2 recommendations for Parkinson's management and interventions are that older adults with Parkinson's disease at an early to mid stage with mild or no cognitive impairment should be offered individualised exercise programs, including balance and resistance training, and that's grade 1A, and I think Lisa touched on that as well. And also they conditionally recommend offering exercise training targeting balance and strength to adults with complex phase Parkinson's, if supervised by a physiotherapist or other suitably qualified health professional, and that's grade 1C. Better fidelity and adherence is seen in supervised programs, and a recent Cochrane review that evaluated the effectiveness of interventions to prevent falls in Parkinson's disease showed with high certainty that exercise reduced the rate of falls in this group by 35%. With respect to freezing specifically, a systematic review showed that exercises aimed at general health benefits had no effect on freezing. And specific training, including teaching of freezing prevention strategies like cueing or action observation and specific prevention strategies in the home, reduced the severity of freezing. Largest effect sizes were found for exercise targeting freezing and compensatory systems, so cognitive training, dual tasking, balance training, treadmill training with cueing, and obstacle avoidance training were all useful. Finally, supervision and modification of exercise for individuals with Parkinson's at a complex stage or with moderate or severe cognitive impairment requires specialist skills, and as such, these individuals may not be able to follow a self-directed program, and for safety and falls prevention exercise interventions should be integrated in general mobility and ADL rehabilitation. Thank you, Sue.
Thanks, Diane. Okay, so moving on to working group 8, which was falls and technology. And I was actually quite surprised. I thought this section would be larger, perhaps have more detail, more information in it, but it didn't. So they looked at the evidence for use of digital technologies in falls prevention. It's relevant for all settings. And they have recommended as an expert grade, grade E, that to use telehealth smart systems in combination with exercise training. That's not to say that's going to prevent falls at all, but it might help to reduce the risk. So wearing the evidence, the wearable technology is effective for detection. And in recommendation 2, so this is an intervention, again, relevant for everybody. If a wearable is used in an exercise program to prevent falls, it increases participation. So that's quite important information that we need to be looking at. But there are more RCTs that use technology to improve falls risk assessment. They are required. There isn't actually that much out there. The working group 9 was around falls in low and middle income countries. It's well worth looking at, but I didn't feel that Australia was a low and middle income country, so we did not cover that. Lisa, your turn.
Thank you. So the objective of working group 10 was to assess if multi-domain interventions, so that's interventions with 2 or more components that are individually targeted, can reduce the rate of falls in community dwelling older adults. So the first recommendation with grade 1B evidence is that multi-professional, multifactorial falls risk assessment should be offered to community dwelling older adults who are identified as being high risk of falling in order to guide tailored interventions. And as Sue mentioned earlier, a broad assessment approach such as the comprehensive geriatric assessment approach is recommended. And the second recommendation then that follows on from that multifactorial assessment is that multi-domain interventions should then be offered. And this also has grade 1B evidence. So the effective multi-domain interventions should be based on the modification, where possible, of the falls risk factors identified in the individual and not on a generic intervention regardless of the individual's characteristics. And it just mentions a number of times that the monitoring of the uptake of the intervention is really important because this is obviously key to the effectiveness. The next slide, Sue. So the recommendations 3 and 4 then detail the components of what this assessment should include, and then the associated interventions that are most likely to reduce the rate and the risk of falling in the community dwelling older adults. So the assessment domains are listed on this slide. And within the guidelines, further information on what should be assessed within each domain are available, and we've obviously covered some of them already here today. And then, as Sue mentioned earlier, the other domains that weren't covered by the main working groups were covered by some of the ad hoc groups, and there's additional information about these domains in the guidelines. On this slide, we have a list of all the intervention domains. And just to mention again that the key is that the intervention domains encompass 2 or more components that are individually targeted to the older adults based on the findings from the assessment, not any standardized set of interventions applied to everyone. The strength of evidence for the interventions differ per each component. But overall, the evidence is that multi-domain interventions, when offered and adhered to, are effective for reducing the rate of falls in moderate to high risk community dwelling older adults. The guidelines mention that in a review of all published guidelines on falls prevention and management for older adults, that all of the guidelines included exercise interventions, and then the majority included medication reviews, environmental modification, footwear and vision correction, and cardiovascular interventions. The environmental interventions to reduce falls hazards in and about the home are most effective to those who are at higher risk. And in terms of practical tips, as Sue mentioned in one of her previous slides, it is really important to understand the older adults' attitudes to falls and the priority that they give to their prevention, as this will influence whether or what type of intervention that they will engage in. So any plan developed to prevent falls should incorporate the values and the preferences of the older adult and their caregiver where appropriate. And just to know that in terms of implementation, the guidelines did refer to 2 relatively recent studies from the UK and the US that illustrated that within current health systems, it can be difficult to implement interventions that are proven to be effective in smaller research trial settings. And therefore, one of the research priorities in this area is to have more studies on optimal implementation of interventions. And another research priority is to assess whether specific components aside from exercise can be prioritized as interventions. That's all, Sue.
Thanks, Lisa. Diane?
So as Sue mentioned earlier in the presentation, one of the really important working groups was around older adults and their perspective on falls, and Lisa's just touched on that. So uptake of falls prevention interventions is influenced by how seriously older adults view falls and their belief that they are preventable. And this is really valuable information and builds on all of the work that's been done in Australia and elsewhere recently about engaging clients in their own healthcare and their own falls prevention. So recommendation 1 is around stratification, and the working group recommends clinicians should routinely ask about falls in their interactions with older adults, and that's relevant in all settings. Clinicians cannot rely solely on older adults reporting falls. Studies indicate that many do not for a variety of reasons, and this appears to be more common among males, with less than a third reporting falls spontaneously to clinicians. Asking about falls should be done at least annually on admission to facilities or services, at transitions of care, and during other clinical encounters. Recommendation 2 is in respect of assessment. As part of a multifactorial falls risk assessment, clinicians should inquire about perceptions of the older adult holds about their falls, their causes, future risk, and how they can be prevented, and that's grade 1B evidence. A review on the perspectives of older adults showed that many have low levels of knowledge about the causes and prevention of falls, and many have erroneous beliefs about the causes, their own risk of falling, and how to best minimise the likelihood of future falls. So knowing what the beliefs of older adults are would allow clinicians the opportunity to answer questions, address misconceptions, and provide accurate information about falls and their prevention. In terms of intervention, which is recommendation 3, the group recommends that care plans developed to prevent falls and related injuries should incorporate the values and preferences of the older adult, as Lisa said. Engaging older adults in a discussion about their preferences coupled with shared decision making can improve adherence to recommendations and improve outcomes. It can also be helpful, and we've spoken about this previously too, when discussing falls prevention strategies, to include improving mobility and achieving functional independence as the positive goal for recommended interventions in addition to preventing falls. And I think that's a message that we've had here certainly over many years. Don't talk about the things we're going to do just to prevent the falls, but add that positive slant about things that are important to the older adult around functional independence and mobility. Thanks, Sue.
Thanks, Diane. Over to you, Lisa.
Okay, so the last working group we're looking at concerns about falling and falls. And the objective of this group was to make recommendation on the assessment of an intervention for concerns about falling as part of the comprehensive falls risk assessment. You can pop to the next slide, Sue. So the first recommendation with grade 1B evidence is to include an evaluation of concerns about falls in the multifactorial falls risk assessment. They recommend to combine the assessment of concerns about falling with the balance and gait assessment, as it will put the degree of concern into context. The rationale for including concerns about fall as part of the comprehensive assessment is that it is a measure of the older person's perception about the falls that they have experienced, the impact falls have had on their quality of life, as a treatment outcome measure, and also to assess their openness to various interventions. So for example, an older adult who's inappropriately very fearful of falling may be reluctant to increase their physical activity and follow an exercise program if these concerns are not properly dealt with. So as we know, the concerns about falling can be excessive and maladaptive, and then they can lead to activity avoidance, reduced engagement in physical activities, which can then lead to further physical decline and falls. The second recommendation is the use of standardized instruments such as the Falls Efficacy Scale International, or the shortened version, as they have strong to moderate level of evidence for their use in older adults living in the community, and also good evidence for use in acute hospitals and long-term care populations. The third recommendation is relating to assessment and intervention, and it's for the use of exercise, CBT and/or occupational therapy as part of the multidisciplinary approach to reduce concerns about falling, and there's grade 1B evidence for this. They mentioned 2 recent systematic reviews that highlighted that supervised exercise interventions in the community had the largest effect sizes in reducing concerns about falling compared to other interventions. In terms of practical tips, the guidelines recommend that we pay attention to what terminology we use. So fear of falling is the term that's often used in the literature, but the guidelines recommend asking about concerns around falling rather than using the term fear of falling, with the thought being that the word concern is less intense and less emotional than the word fear, and that then it may be more socially acceptable for the older adult to disclose. There was a little bit about concerns about falling and falls prediction, And the review found that concerns about falling is an inconsistent predictor of future falls. The association between concerns about falling and future falls is thought to be complex, and the expert opinion is that concerns about falling is unlikely to be the primary cause of falls in older adults, and the relationship between the concerns about falling and future falls is likely more dependent on the individual's physiological falls risk. So some research indicates that for some individuals with poor balance or mobility restrictions, that concerns about falling may actually have a protective effect, while for individuals with higher functional capability, the presence of concerns about falling has been associated with increased risk of future falls. And finally, just some research priorities is to identify preferred tools for assessing concerns about falling in different subgroups and whether combinations of interventions can have larger effects on these concerns about falling. That's it, Sue.
Thanks, Lisa. Okay, so I'm not going to go into the ad hoc groups. I'll leave you to do that. But these are the 10 ad hoc expert groups, all with the different topics there. And 7 of them have come up with recommendations as well from the literature. So they're all excellent, but you do need to go and have a look at them and look at what they advise. This is the teach back, which I mentioned. It's a technique for healthcare providers to ensure that they have explained the medical information clearly so that the patients and their families understand what's being communicated. And it's one of the recommendations for delivering patient education, but looking at the wide range that was provided within the guidelines, this was one of the easiest ones that I felt could be readily implemented. I'm going to leave you to find out more, but that is around language and what words we use and also how we deliver it. So where do we need to go from here? From the huge amount of information that we've given you, but also what is obviously in the guidelines, we need to identify where changes in practice are required. What have you got in place already? What's not in place? What's doable? It has to be doable. Consult with your team, develop those guidelines and those policies and those resources that are required and implement them. Develop the education for staff, for patients, residents, consumers, caregivers, family. Do consider teach back. I did think that was quite good. Learn the language. So how do we talk to patients and consumers? Have we got the right language? Are we using the right words? And partner with the patients and the residents and consumers all the way along. Their input is essential and it's extremely valuable. When you go to the full guidelines, so remember I said that there was an abbreviated version and a long version. When you go to the long version, remember that the first few pages are very, very simple. They have the working group, they have the recommendation. So it's very, very easy to read. I thought about how we could put this together to try and make everything that we've just heard, the massive amount of information, how do we put that together to mean something? And so I've just looked at a hospital. My apologies if when we have community and care home staff here. But if we have the FRAMP, the Falls Risk Assessment and Management Plan, which many hospitals do or are still using, we're actually halfway there. In fact, we're probably almost all the way there. So the FRAMP is a really good tool, but we don't necessarily need the screen, not for patients that are in hospital. Those that are coming into ED, that's different. But those that are actually in hospital, that everybody is at high risk of falling. everybody over 65 and in those other particular groups that are mentioned. It's the multifactorial assessment and the risks that are required, and then we can put the multi-domain interventions into place. We do need to look at what policies and guidelines we have and what education we have and is delivered. Not to use scoring tools as well for risk assessment, that's been advised against. So if we were just looking at the multi-domain falls risk assessment, this is the assessment, this is what we need to be doing. And a lot of this we are already doing, and a lot of this is on the FRAMP or is within our practice. This is what we normally do. So from what we've learned today, we need to have gait and balance, routine assessment for falls. If somebody falls, that they need to have that post-fall assessment. We need cognition assessment, that needs to be routine. And it also needs to include the caregiver. So not just the older adult, but the caregiver as well. We need to be assessing the perceptions of the older adult so that we can tailor that care plan. We need to assess and evaluate the concern about falling, so we need to consider using the FES. We need that cardiovascular assessment, the orthostatic hypertension assessment. We need to ask questions around dizziness and urinary symptoms. We need to identify the FRIDS and what are we going to do about that? The vision impairment, and we need to assess, and use visual measurements. There's a variety of these that can be used from the bedside and beyond. We need to ask about hearing impairment and the nutritional status. The depressive symptoms, we also need to be assessing for that. That's very, very important. And pain as well. So the depressive symptoms and the pain, they're recommendations from 2 of the ad hoc groups. So again, need to have a look at those. But then we need to look at the interventions. So we've done all the risk assessment. What interventions are we going to put into place given what we've just heard today? So gait speed and deprescribing. So consider that stop fall. We need to implement teach back or something similar and make sure that the falls education is tailored directly to the patient. Implement alternatives to any type of restraint that we're using for falls prevention. Prevent that deconditioning in hospitals. So we know that patients are coming in deconditioned and that they get more deconditioned. We had Brian Dolan talking to us a couple of months ago around this exact topic. And post hip fracture, there needs to be an individual and progressive exercise program. Parkinson's disease clearly needs to have its own little world, I think, and need to look at what we need to do, the 3 risk factor assessment tool, and look at those multi-domain interventions on a very specific PD assessment. A question to ask: can wearable technology increase participation in exercise in hospital? Don't know. Again, what is the perception of that older adult? How do we tailor the interventions to their beliefs, their values, and their preferences? And bringing it back to those touch points. So whenever we see an older adult, we really should be asking about falls. And this is the algorithm that has been developed for those touch points when the person is going to the GP or having their annual health visit or having community visits, or they're presenting to ED with a fall or a related injury. This algorithm is very clear and it's very simple, and certainly one that can be easily put into a policy. So I just want to say thank you, because I realised it was a massive presentation, extremely dry, but thank you so much to Lisa and Diane for the work that you guys have completed within this presentation. Very, very much appreciated. We will send out an evaluation question but a copy of this presentation and the link to the recording will come out to everybody who registered via Eventbrite, and it will take between 1 to 3 weeks. It's a very large file, so it will come out as My FT. So you'll get 2 emails, one with all of the information and another one with the instructions on how to access My FT. We'll just go into questions, as I know that there was one. Right, so Julie Elliott, this was while you were talking, Lisa. What professions are able to use the GS and the TUG assessments?
Yeah, good question. It doesn't actually specify that it has to be any particular profession. And I think when you look at that algorithm where it sits across the top, it's for, they're recommending use of it to identify who's either a low or an intermediate risk of falls. So I think it's probably just about whoever is, doing this screen, that they are trained and know what they're doing when they're looking at the gait speed. So in the guidelines, what they're recommending is measuring gait speed at a person's usual gait over a distance of 4 meters with their walking aid if necessary. And on one of the slides I included one of the so there's a link to resources that's related to the World Guidelines webpage. I just had a check, and that those resources haven't been uploaded onto that website yet. But the other link is a website that goes through loads of different outcome measures with instructions on how to perform them, including a gait speed assessment. So it may be why they chose that gait speed as one of the outcome measures to use, because it is a generic assessment that doesn't involve a whole lot of training in order to be able to complete it.
Thank you, Julie. I hope that answered your question. We're planning on doing some more sessions which just take one working group so that we can look more in depth into that working group. If you're interested in that, please let myself know, or Lisa or Diane, or through the evaluation link that will be coming. Does anybody else have any more questions or thoughts or comments? What happens in your areas? I love this. Everybody goes silent. No? Okay. All right. Well, we'll close there. So on behalf of all of us, thank you very, very much for joining us. And we hope that you've come away with more knowledge about the World Guidelines and what you can do within your areas to improve falls. So thank you.